Well, hello, everyone. My name is Janelle Simmons, Manager of Programs at Sigma Xi, the Scientific Research Honor Society, and you are here at our next installment for our distinguished lectureships on the COVID-19 pandemic. I would like to thank Chair Mark Emhoff and the Committee on Lectureships for hosting these series of lectureships to talk about the impact of the COVID-19 pandemic. So at this time, I would like to introduce to you all our moderator, Dr. Kiki Sanford.
Thank you, Janelle. Thank you, everyone, for joining us for another of these distinguished lectureship series on COVID-19. And I want to thank Sigma Xi for inviting me to moderate. Once again, I am quite enjoying this panel. This series of talks. Today, our speaker is Dr. Shweta Bansal. She's a Provost's Distinguished Associate Professor at Georgetown University's Department of Biology. She was previously at the CIDD at Penn State University, the Fogarty International Center at NIH, and at the University of Texas at Austin. Her work is in the field of interdisciplinary mathematical biology with a research focus on the development of data-driven mathematical models for the prevention and containment of human and animal infectious diseases using tools from network science, statistical physics, computer science, and statistics. She's going to give us a presentation for the first part of this session. Please enjoy the presentation. If you have questions, please ask them in our question and answer option. You can also make comments in the chat. We will do our best to monitor that. And at the end of the presentation, I will ask a question or two, and then we will get to audience questions. So with no further ado, Dr. Bansal, thank you for joining us today.
Thank you so much, Dr. Sanford. Really grateful to Sigma Xi for having me today, and I'm really happy to be talking to you, Dr. Sanford, today, and really to be here with you all. My goal is to, really just give a fairly high level, summary of some of the things we're thinking about at the moment, and then, as you said, we'll sort of switch over, and I'd love to hear what folks are thinking about, so we can chat about that. So 2020 has been a unique year in many ways, but for infectious disease modeling and modelers like myself in particular, the field has been thrust into the limelight in a huge way, which is in many ways what every scientist wants for their scientific approach. But there's, of course, a lot of misunderstanding about the field as well. So what infectious disease modeling is in general is that it's a systematic way to translate assumptions and data regarding a process, something like disease transmission, into quantitative estimates of how something like an epidemic evolves in space and time. Models essentially allow us to have a laboratory within our computers to carry out experiments that are challenging to do ethically or logistically. But really, these models are not intended to be crystal balls. Because models can be enticingly relatable, it's easy to view model results as forecasts or predictions for far into the future. But this is inherently impossible to do, and I'm happy to chat more about that during our Q&A. So the field of disease modeling it's highly interdisciplinary. It draws from a whole host of natural and social sciences. And really, it ends up being a link between policy and basic science. So the development of a model starts with the policy question and then integrates the current sort of best scientific understanding and available data to build a model that helps address a given policy question. After a model has been validated and analyzed is when we can use it to sort of generate new scientific insights as well as policy advice. I'll say that because infectious disease models in particular aim to study processes that we sort of all know about, like human behavior and things that we experience, like disease outcomes, they can be quite compelling and often quite intuitive. But this really does amount to a big potential sometimes to cause significant damage through policy. So because of this, and particularly in a time of crisis like a global pandemic, it's really critical to carry out the evaluation and validation steps of this process with care. So the flavor of the models that modelers sort of think about can vary quite a bit, right? There's the fundamental modeling questions as to how you take something like disease transmission that happens between individuals and translate it to what might be happening within an entire population is of interest. There's ecological questions we might be answering about how the interactions between a pathogen and a host dictate which diseases establish themselves in human populations. There might be epidemiological questions where we're just interested in the determinants of the disease patterns that we're seeing in a population. And of course, there's applied public health questions about designing and assessing the impact of interventions. And for many of us in the field, we really aim to address this whole range of questions, which of course makes our work challenging, but also quite rewarding. So when it comes to data, regardless of the type of infectious disease modeler someone is, data is fundamental to all our work. Sometimes the data are summarized into individual parameters that capture information about the pathogen and the host, things like behavior and susceptibility, as well as the environment. And those are all summarized often into simple values called parameters, and other times the data involved can be quite complex. And the depth of how much data and what types of data are required really does ideally need to match the question, the policy question, or the basic science question being posed. In the case of a novel pathogen like SARS-CoV-2, where we don't have a lot of a priori information about the pathogen, and in many cases the host, really relying on epidemiological data, disease data about where the disease is and when it's spreading, really using epidemiological data becomes key. We see this type of data being usually collected by local, state, federal health departments, but resources are often limited with those agencies for doing disease surveillance. So often these data aren't high resolution. There's often lags that they are susceptible to, and combining these data from lots of different sources is challenging because they vary in different ways and in unknown ways. So really to fill this gap of being in a data poor environment for a field which asks quite urgent and compelling questions, modelers like myself have been investigating the use of alternative data sources that can be repurposed for epidemiological purposes. So examples of this include administrative health data, so electronic health records or transaction data from healthcare settings, social media on which individuals disclose a lot of information about their behavior and their health, and mobile records, which have been shown to be sort of key to help us understand how populations are moving around within a geographic space. There's, of course, a ton of opportunities that these types of data streams provide. They provide improved resolution, they provide timeliness, and they really are at very, very large scales usually. So if you think about mobile records, for example, if I have data on mobile phones from the entire US, I'm looking at data from tens of millions, sometimes hundreds of millions of individuals, which is a far cry from what traditional data ends up being. But the promise of these data streams really must be viewed with caution, as there are now new limitations that arise, such as representativeness, noise, and of course, ethics and privacy when you're talking about very fine and detailed data. My research group really works with integrating such data sources into disease models, and so we end up needing to be quite careful about this balance between these opportunities and challenges. So one of the primary data sources that we've been using at least for information on disease is administrative health data coming from medical claim. So every time an insured individual visits a physician, a healthcare provider, that provider needs to be paid, so they complete a medical claim. And on that medical claim is not only, of course, the billing information that the provider cares about, but there's also information, demographic information about the patient and health status information about what their visit was about. So these type of data, when aggregated to for the entire U.S., can really give us a detailed view of where disease is and how it's spreading. Usually the advantages of such a data set are that we can look, it's quite high scope, so we can look at the entire US at the same time, and it's data that's been collected in a uniform way. So we're able to deal with that issue of aggregating disparate sources. It's high coverage because it includes millions of patients, and it's high resolution. Either it's at the individual level, or usually we study it at a fine geographic level, like zip code or county level. Such data can also be really timely and demographic specific. So really to understand such data, we can't just run with the raw data because of the limitations that I mentioned a couple of slides ago. So to model such data, we use a combination of mathematical and statistical models that are hierarchical in nature, and spatial, particularly because of our interest in the questions that are spatial. So to characterize the spatial distribution of disease in the US over time, we first incorporate a disease model, something like an SIR or an SEIR model, which many of you may have heard of in recent months. And this encapsulates the disease transmission process from which emerges the classic epidemic curves that we've all come to know and love now of where disease escalates at an exponential rate and peaks and then comes down. Second, we incorporate a lot of covariate information that captures the various demographic, social, environmental, and behavioral processes that underlie disease transmission. If we're hoping to understand how spatial variation in disease can be explained in a country like the US, really understanding the variation in these underlying processes is key. Lastly, we also are careful to keep in mind, of course, that this data is from an administrative data source and we're repurposing it. And so this is often, the data are biased by who has access to care and insurance and who is actually seeking care. So we incorporate a host of measurement covariates into our models as well, which helps address that limitation. So we've been able to use this approach in a number of other systems besides thinking about COVID. Flu is one of the primary ones. So I'll just walk quickly through some of the examples of what we've done with such data. So we've thought about how to, for one, we thought about how to optimize disease surveillance. So this map here on the left is sort of what these raw data look like. And the map on the right is the results coming out of a model like the kind I'd shown on the previous slide. Again, fitting the raw data through such a model really allows us to deal with those biases that we might be observing and smooth out some of the errors in the data, or smooth out some of the missing data as this map here on the left has. In addition, it allows us to do model inference to really figure out how those underlying factors that we put in information about the social, the behavioral, the environmental, and so forth, how those actually predict disease transmission. So, in this context, for having done this for flu, we've understood that humidity is quite key to driving flu transmission, but some other factors that we may have expected to be important are not. On the right here is also inference about which of these measurement covariates are really key. Second, we've thought more recently about how we can use such data to try to understand the disparities in disease burden. There's definitely geographic variation. If I show you the map of any infectious disease in the country, or any chronic disease for that matter, you'll see that there's high spatial variation in that map. And that spatial variation, one of the reasons it arises is because we have huge health disparities within public health in the US. Those disparities are due to socioeconomic variation, it's due to structural racism in many cases. So really using these data to understand what those disparities are has been important. So we've again used a model such as this to really estimate that the Southeast United States, which is something that's been found in other studies as well, the Southeastern United States really has a disproportionate burden that they experience for diseases, respiratory diseases like influenza. And again, we can also use this type of model to understand which factors drive that disparity the most. So in this case, for example, we find that poor health, which leads to stress and higher susceptibility, and absenteeism for children from school really are the driving factors, whereas other factors like healthcare access maybe are less important. Thirdly, we can use such data to think about how to really deliver public health in a more efficient way. So at the moment, this map represents the Health and Human Services administrative regions that are used for basically allocation and communication of public health resources like vaccines and antivirals. These regions are really ad hoc. They're designed from an administrative perspective. But when we look at the epidemiology of something like influenza, we see that there's not a great match between these regions and where flu is and how it spreads in the country. So what we've done is we've used this high resolution data from claims to really come up with the epidemiological relevant regionalization of the country. So this map shows that regionalization where each color represents a region. So we have far fewer regions, for example, than the HHS regions. And essentially 2 counties are within the same region if they experience similar epidemiological dynamics, if their influenza curves, epidemic curves look the same from year to year. And this means that we can, if we sort of used a regionalization such as this to implement public health policy, it would be really, really efficient for resources. Lastly, I'll give the example of a non-influenza example of childhood diseases, especially vaccine preventable childhood diseases like measles, where we're using such data from claims to really think about how behavior varies across the country geographically. So this is a map that shows vaccine refusal rates around the country at a county level. Again, it's highly variable, so even just characterizing this has been a real shift in how we think about vaccine refusal. And it allows us to identify clusters of locations where you've got pretty low vaccine refusal versus other clusters where vaccine refusal tends to be pretty high. It's also, working with models has really allowed us to also think about how different social processes might be driving these patterns. So, and pointed out a few of these clusters that we're seeing around the country in this behavior. That clustering can occur from a few different social processes, either because you just have individuals that are like-minded, that both refuse vaccine, living close to each other, or you have a process where one individual who is a vaccine refuser is convincing their friends and within their social network that they should also refuse vaccines. So really being able to understand these social processes is key to intervening against them. So finally, I'll get to COVID here. So we're, of course, also using a big data modeling approach to understand COVID. All of us around the country have sort of been following the status of COVID across the US through dashboards that are created by our state health departments, or through the heroic work that's being done by news outlets around the country to bring this data from state health departments together. But as I mentioned earlier, in this context, the data collection processes can vary vastly in different states, and they've been plagued by problems. And most importantly, they only count test-confirmed cases, which may only be a tip of the iceberg when it comes to COVID, especially in locations where testing is weak. So to address this issue, my research team has been using claims data to develop a syndromic surveillance system for COVID. Syndromic surveillance is basically a strategy that relies on tracking disease based on individuals with symptoms rather than only relying on test confirmations. So looking at this plot from about March to that mid-September or so, with the y-axis being the number of normalized number of COVID cases, we see that the dynamics of test confirmed cases, which is in orange here, looks quite different than that of suspected cases in blue, who are individuals who only have the right symptoms that have been, but haven't been test confirmed. So from a dynamics perspective, these two are quite different, and it's key to understanding COVID dynamics to sort of maybe follow what might be happening with this blue curve. I'll mention that there's a sort of a lot of machinery under the hood here that I'm not talking about, but I'll be happy to come back to that later if anyone's interested. So along with taking data on disease, again, we really need to be careful in thinking about covariate data, and we need to do our best to have that be reliable data at a fine spatial resolution. So county level is what we primarily work with, and we're using a wide range of sources to get demographic, employment, health data, and data on the environment. Most of these come from governmental surveys, so surveys that are done by the CDC, or from census, for example. But in some cases, we're also able to incorporate big data sources into the covariate part of our models. So examples here are this map here, which is showing social distancing behavior around the country, and this map here at the bottom is showing travel behavior around the country during COVID. Both of these data sets come from mobile records, either from call records or from location-based app usage. And basically, these are data sets on tens of millions of individuals around the country, and really help us provide a real-time, almost real-time estimation of what behavior is looking like in the country. This has been, this was not really the case in the US. Availability of this data set was not possible in the US before COVID. So this has been just a game changer in how we think about incorporating behavioral data into disease models. So I want to make sure here again that we get to questions. I just want to quickly mention some of the questions that we're addressing with these types of approaches. We're, of course, as I mentioned, looking at what the pandemic looks like beyond just the test confirmations and the hospitals and the hospitalizations and the deaths that we're seeing. What might be the early dynamics of COVID-19 in the US when we know for a fact that testing was quite weak. Of course, we're interested in mitigation strategies and figuring out which ones are most effective at controlling transmission. We've sort of taken the kitchen sink approach across the US, and there's bound to be a more targeted approach that can be a lot more efficient for both disease and for downstream consequences to the economy and mental health. We're also, of course, from a scientific perspective, a bit more interested in how the various socio-environmental and health factors are impacting the dynamics of COVID-19. And lastly, COVID-19 doesn't exist in a vacuum. So we're interested in sort of what the interaction between COVID-19 and other respiratory infections and even non-respiratory infectious diseases looks like, and how that might be shifting as we go on, so that we can be better prepared to respond to those infections that are not suddenly disappearing from our radar. So I will sort of pause with that. I want to make sure to sort of give a huge shout out to my wonderful lab group that just have all been heroes in the great work that they've been doing, and really hats off to all the young scientists out there that have been contributing to COVID, or just keeping science going during this year. And just quickly on that note, I'll put a quick plug in here for a new graduate program that we have at Georgetown University called the Global Infectious Diseases Program. This program has two tracks, one a policy track and the second an infectious disease modeling track. So if infectious disease modeling has gotten your interest and you're looking at graduate programs, please do consider it. So with that, I will turn it over back to Dr. Sanford. Thanks so much.
Thank you. This is just a wonderful introduction to the work that you're doing. And I already have so many questions. I'm so interested in this. I think first, it's really from the data side of things. We have seen in the media conversations about the different testing-based data sources. So we've got the CDC reporting data from various counties and states around the country, and there have been questions about the data that's coming from those places. How how does your data looking at the more aggregated social, behavioral, mobile and medical claims data, how does that compare to the data that is being reported from the official sources?
hmm Yeah, that's a great question, and something, of course, we've been thinking a lot about. So first, I'll say, right, the relationship that Americans have to infectious disease data has changed in a huge way this year, right? Most people weren't used to looking at something like influenza data at the CDC website every season, and if they did, they would find fairly coarse-grained qualitative maps. Whereas this year we've shifted in this big way to very quantitative, routinely updated, high resolution data sets, and it's really changed how people incorporate that information into their lives. And so that's been a huge game changer. But as you alluded to, there are some major issues with the data that we are seeing. Of course, any data is data, and we'll take it. It's better than no data. But there really is only a single source of information, even though multiple outlets and even private groups have been displaying these data in dashboards. Really, there's only a single source of data, and that's state health departments. They're the only ones who are collecting these data from hospitals and from testing centers within their state and aggregating it. And in normal years, it's the job of the CDC to then take all of that data and put it in some aggregated and uniform format. But that's been challenging. And so what we're really seeing in these dashboards is just a mix of whatever the state's guidelines are for testing and for reporting, and whatever the lags they might have. And unfortunately, some states have even abused that role and really manipulated data in many cases, right? And so those are instances in which the data can actually really cause some damage. The advantage of something like the data set that we're using is that it's a uniform source, right? All the data has been collected in the same way, and that is that it, in the case of the medical claims, it always comes from an individual seeking healthcare, and there being a claim that's filed as a result of it, right?
Yeah.
So yes, there are biases in this data, and there's limitations, but they're uniform biases and limitations, which really allow us to have trust that when I look at a county in California versus a county in Wyoming, then I can actually compare those disease outcomes in equivalent ways.
Right. So there's a little bit in the comparative aspect. There's more standardization. Or
That's right.
yeah. Okay.
That's right.
So thinking about the predictive ability of these models that you're working on, there's one question from our Q&A from William Paceman. If the model isn't predictive, what value does it have?
That's a great question, right? So I'm sure some of you, I know Dr. Sanford just mentioned that she saw the study, and some of you probably seen a study out just today in Nature Medicine, where modelers used a model for the United States to estimate the number of deaths that we would be seeing by February, and that number is over 500,000. I'll say that what I want folks to get out of that number is I don't want you to focus too much on that number. Models, as William says, right, are not designed to be used in a forecasting context far ahead in time. And the reason they're not is because any predictions that a model makes, we can will those predictions out of existence. This is not like weather forecasts where, we can't will snowstorms out of existence. And so when a weather forecast tells us, that it's going to snow in 3 days, it's most likely going to snow in 3 days, no matter how much I wish it isn't going to, right?
Right.
But you'll also notice that weather forecasts are only ever 10 days ahead, right? It's a similar process for disease models, but even more so because diseases are driven by human behavior and we don't have good ways at all of predicting human behavior. These models can make projections, but they cannot make forecasts anything beyond a few 2 to 3 to maximum 4 weeks ahead of time. So that study that came out today with over that estimate of a very large number of deaths, is that number plausible? Absolutely, right? We're at 221,000 today and 7 months into the pandemic. So there's no reason to think that if we continue the way we have, that we won't double that number easily. But really, I think what we should be doing is seeing that study as our own version of Christmas Carol, right? We're all Scrooge, and that study is basically the ghost of COVID yet to come. So let's sort of use it as a call to action and really change our behaviors and come up with an integrated policy that's targeted for the US to really stop COVID in its tracks.
Yeah, we do have, you're absolutely right. We have the ability to reduce the transmission in the spring. There was in social media, and I think it was really driven by social media, the idea of flattening the curve, and it
That's right.
just gained traction across the country.
That's
And people were watching the curves, and we did. We flattened the curve. People stayed home. They started wearing masks. They started
right.
taking personal behaviors that did reduce transmission. Is there anything that you have seen in the data that predicts which methods are the best at reducing transmissibility?
Yeah, so one of the big, so that, I mean, that's a question that's sort of been on all of our minds. It'd be nice to not have to do this kitchen sink approach of where we, stop all gatherings and close schools and wear masks and do social distancing. That would be good. But at the moment, that's the best approach we've got. From our data, what we know is that the efficacy of the effectiveness of different interventions actually varies across the country. And again, because we're looking at it at such a fine resolution, we can actually identify how that varies. But what that points us to is that really we need a much more tailored and spatially targeted approach to get to a place where we're stopping this pandemic, stopping this disease from spreading, but also causing less damage to the economy and to mental health. Really, that the approach we're using now certainly should work if we do it right. Wear our masks and social distance and avoid the large gatherings. Really, that should reduce cases. But I think there is a more targeted approach that can be taken with the right data to balance things a little bit better.
Should we be nervous about the upcoming flu season and other infections?
Yes, this is something that's been sort of on a lot of our minds. I'm sure if any of you are keeping up with the news on this, there's quite a bit of optimism about the upcoming flu season. Every winter, we see an uptick. We see epidemics of other respiratory infections like flu and other actually seasonal coronaviruses and a whole range of other viruses and bacterial pathogens. And some of this, sort of excitement, I'm just pulling up a slide here. We've done an analysis of the last flu season, which was sort of coming to an end right when COVID began. And so I just want you to focus a bit on this left plot here. The leftmost point here is October, and the rightmost point is March 2020. And so these two lines, the black is what we actually saw. The blue is what our expectation would have been for this past season if it was a normal flu season. And you'll see that, till about early mid-January, the flu season was right on target to what we would expect. But right when news of COVID started spreading, this really deviated. And the good news was that the incidence of flu, the annual flu season, was really diminished. And so we saw far fewer cases, far fewer hospitalizations and deaths from flu. This could be viewed as good news. And certainly in the Southern Hemisphere, flu has really been diminished in such, in such a way as well, because they have their flu season during our summer. So we've lots of evidence that things may work out, but I'm still actually quite nervous about the upcoming flu season. And there's a few reasons for that. One is that our public health situation doesn't look like that of other countries, and it doesn't look like what it did here in March, right? We're not seeing the huge response towards masks and social distancing that other countries are seeing. Other countries have much stricter requirements, and enforcement is quite stringent as well. So the fact that they didn't see a flu epidemic is the result of all that behavior change, because the things that we do to stop COVID, of course, are also helpful for flu. And so our public health situation doesn't look the same. Our vaccination rates for flu are usually quite low, at 50% at best. And I expect that number to actually to be much lower this year, because most people get flu shots at work and at home, not at home, at school. And if people aren't at school and work, then those shots are being missed. And then lastly, there's some new evidence just out today that co-infections of flu and SARS-CoV-2 can really increase the severity of a COVID infection, which is quite scary as well. So there's, we've really got to keep our guard up here, and really, the good news is we can keep doing the same thing, and we'll win on all fronts with that.
Yeah, I hope people do make the effort that if they are able to get out and get their flu shots, that is something that can definitely, that's one of the interventions that can be a positive benefit to reduce the impact on the public health system. And like you said, if there are synergistic physiological effects that, yeah, to reduce the impact of an infection would be so amazing.
Absolutely.
When we're talking about the cases, the flu, we know how the flu comes in. It hits you and you're taken out of work for a couple of weeks. Hopefully that's it. And then you're done. But with COVID, we know that there are asymptomatic, pre-symptomatic, mild cases, many mild cases that affect the dynamics of how seriously people are taking COVID-19 as a disease. What are some of the modeling aspects that are being looked at, and their importance for understanding how this disease is going to progress moving forward in our population?
Yeah, absolutely. So I would say largely the impact of COVID on individuals has been underestimated. Often it's communicated in a way where it seems like less of a threat than it truly is. Yes, the range of symptoms, the range of clinical disease that patients with COVID experience is quite broad compared to something like flu. But and surely there are individuals that experience mild disease, but there's also a really wide range of severe outcomes, right? So there's systemic issues that COVID can cause, neurological concerns and heart issues and kidney problems. It can, of course, cause death. But in addition to that, one of the really dangerous aspects of COVID is what's being called long COVID, right? This notion that certain individuals who are often quite healthy at the start, before getting this infection, they actually are experiencing symptoms weeks and often months later. And at the moment, we don't have a great estimate of how common that is, but that is, the small data sets that are out there, that's being found in a significant way. And it's not just not just with older individuals or with immunocompromised individuals. This is in like 18 to 34-year-olds, 20% of them still experience symptoms about 3 weeks later after a COVID infection. So there is a lot of damage that that this virus does to individuals. But as you said, that is not an understanding that everyone has. So what we've been thinking about to sort of address this is we've been thinking about how your local information environment really influences your behavior. Again, because we have such detailed and large scale data on both disease and outcomes, as well as behavior, we can start to look at that. My hypothesis is that if you are not in an area where you are observing a lot of COVID detrimental impacts, or if you don't know somebody who has died from COVID, then that really declines your risk perception and hence your behavior. So this is something we're really trying to quantify to better understand that process. And if that is the case, then that means we need to just do better communication for especially in areas where COVID hasn't been very prevalent, because of course there's a feedback loop, right? If COVID hasn't been prevalent, people's risk perception is low, which means they don't engage in the right behaviors, which means COVID will be prevalent in that location. So if we can sort of get ahead of the curve in that way, by using the behavior and risk perception understanding to really get a handle on where it might be hitting next, that might be a huge win.
That might be very huge. And as we're talking about the influences on how people perceive their risks, social media is huge in this as well. An anonymous attendee asks, you mentioned that social media plays a part in our data gathering. Do you believe social media is more beneficial or destructive when it comes to the public's perception of data and information on issues like COVID-19?
Yeah, I would say it's certainly a mixed bag with social media, right? So there's the use of social media within data analysis and modeling studies themselves, right? So a lot of individuals, a lot of my fellow modelers have used social media data in modeling studies to, in some cases, understand where disease might be. The idea that somebody tweeting "I have a cough" gets translated into they might have flu, right? So that's one way it's been used. What I think is a better use of social media data is to measure how people are perceiving risk and their behaviors, what they're doing about it. And that's been something we've done, especially with our vaccination work, to sort of get a handle on sort of how much vaccine confidence is there in the population measured through social media data. The second part, and I think this is maybe where the question was, is how is social media contributing to our communication about this virus? So I would say yes, it's really expanded who is getting the information and data on infectious diseases, on COVID, and how quickly that's happening. All of that has been for the positive. Again, that's been a real shift in how the American public really interacts with data on infectious diseases. But yes, of course, misinformation is a problem that is central to our times, and I can't say that this field is by any means immune to that. And I'm happy to see that we're sort of seeing private companies sort of step up and try to take some actions towards reducing misinformation. Those of you who are on Twitter recently changed their rules around liking and retweeting and so forth, so that misinformation is reduced. So clearly this is a problem we're going to need to keep solving. But I think overall it is really helping information dissemination in a big way.
Yeah. Do you know of if anybody's looking at the data from social media and the misinformation that's being spread, and on how that's affecting interventions in different regions?
Yeah, I'm not. I don't know of anybody who's looking at the combination, but certainly lots of folks in my field are looking at just those data to even estimate misinformation for starters, because even getting a handle on that can really help us with disease models, because they can, again, we can integrate them as another covariate to understand that progression from risk perception to behavior change to disease transmission.
Yeah. Looking at this this past year, and then also starting to look toward the winter season to come and potentially into the year to come, there were lots of errors made in the public health sphere in the response in our country. What were some of the errors that were made that you have you have been able to identify, and how do you think we can do better there?
Yeah, that's yes, that's definitely a question we'd love a redo, a do-over of
Can we,
2020, honestly, right? Yeah.
yeah, can we
Can
try
we just,
again? We can
yeah,
do way better.
exactly. I mean, we're all living our lives over Zoom and videos, and those you get do-overs in those often. So maybe we just need to do that. So yes, absolutely. There, hindsight is 2020, and so there's always errors that those of us in the public health community sort of identify after a crisis has passed. But yes, of course, in 2020, and especially in the United States, there have been a large number of those problems this year. The few that come to mind that I think have really changed the course of how we have experienced this crisis. One is the lack of a national level, sort of integrated and coordinated response. Public health departments at the local and state level can only do so much, and honestly, they're really only responsible for the lives and the health of their those who live in their state. But really, this idea that the United States is not only large, but it's really spatially heterogeneous, requires that coordinated response at the national level, and we've just largely been missing a federal level response this year. The other two things, of course, have to do with intervention. So we did a good job in many states, at least, of responding quite, during the early stages of the pandemic. But in most cases, that response came quite late. So even if it was a full-fledged lockdown that a state instituted, if it came just even a few days late in some cases, that had huge differences in sort of where we see the pandemic today. On the best side, the example is California, where lockdown was instituted early in March, and that California's epidemic looked quite different than other states as a result. The other thing on interventions is that we didn't keep them going long enough. So summer came, and we all had been sort of doing our best for a few weeks, for a few months at that point, and we kind of wanted that prize as for being so good for so long. And there was pressure from businesses and pressure from individuals, and so most states lifted those lockdown measures too early. And unfortunately, that is going to mean that we have to keep going back into that cycle, right? That cyclical nature of lockdowns and surges and disease cases really comes from the fact that if you don't keep those lockdown measures, in place and in a strong way long enough, and you don't do them early enough, then we're sort of always going to be stuck in this cycle. And then, lastly, just the spatially targeted approach, I think, is not something I think anyone would have thought of from the get-go. But I do imagine that if we do that in the future, it will have a big impact.
Yeah, it seems like local regions can take a look at the epidemiology of their curves of how the disease progresses, how the virus spreads within their population, maybe from this past year, and say, okay, so this is when we integrated our interventions previously. Maybe if we do it when we see the curve moving in this direction a little
That's
at
right.
this point instead, and just kind of keep track of that, maybe that can be informative for future.
Yeah.
Yeah.
Please, go ahead.
Um, Anonymous attendee asks if there are occupations in your field of work for nurses, healthcare workers that are interested in the data statistics side of things, and how do our healthcare workers take this data and put it to good use in their work?
Absolutely, right. So of course, healthcare providers are one of the users of models and these data that we imagine and that we have in mind as modelers when we're designing and developing these models. I would say, we want to work with healthcare providers and public health decision makers as partners, right? So we try to do this best possible, at least in non-crisis times when not everybody is actually occupied with dealing with the crisis on hand. Really having those partnerships and having the process of developing a model be a partnership and an iterative process is key to having the final outcome be useful to those who need to use it. That process also absolutely needs to include that validation and that evaluation that I had mentioned at the top. When, especially when we're dealing with crises, it's really easy to drop those steps because they do take time. But when it comes to infectious diseases, we're talking about policy decisions and clinical decisions that are dealing with people's lives. And so doing those checks, that evaluation, that validation, that verification on our models, and really putting out information that is, that is credible, is quite important as well.
Yeah. And Corsi would like to know if there are any preliminary findings from the questions that are being addressed that you would like to share.
At the moment, I am not going to bring any of those up. I'd say they would take longer than the time we have today to run through. Again, we basically keep finding that thinking about spatial variation, spatial heterogeneity is important, but then also spatial connectivity. And one of the things we've found is that not only do we need to think about each location in its own context, but we also need to think about each location not as independent, because the counties within a given state or states within a given country aren't disconnected from each other. There's the flow of people back and forth through commuting and air travel, and there's the interactions that we all have socially that make us connected as well through social media and through traditional media. And so thinking about that connectivity is quite key as well. But please keep stay tuned for a more detailed version. We'll post on Twitter when it's ready.
Wonderful. Yeah, I'm wondering about you had the graph that showed air travel across the United States, and it made me quite happy to not be on the East Coast and to be over in Portland, Oregon.
Yes,
okay, there's
indeed.
travel here, but it's really not as much. So I'm happy.
I will admit that this is actually just a sample of that connectivity, because you might imagine that if I were to visualize all of the connectivity. This is from April, even at the height of the lockdown, the connectivity between locations in the United States was massive, which is, again, one of the things we're really trying to incorporate here. So this is a very small sample of the overall connectivity, but yes, you're absolutely right, Dr. Sanford, that it's a lot more connected on the East Coast than on the West.
We have a few more minutes here, and one issue that we haven't talked about yet that is it's big in conversation in the media and I think in communities, is this idea of herd immunity and the strategy to build immunity within a population so that the people who are immune can protect those people who would be more negatively affected by a disease. And this is one that's currently being considered by the Trump administration. Is it a viable strategy? Does the data suggest that this is a direction that we should be going? And can you talk about that?
So if anyone wants to stop listening after this, the short answer is absolutely no. This is not a viable strategy, but let me say a little bit more. So herd immunity is this idea that if there are enough immune individuals in your population, then those who aren't immune or protected essentially can be firewalled off, right? So if you only have a few individuals in the population that are protected, there's still enough transmission pathways for the disease to get around. Whereas if you have enough that are protecting certain individuals, then that buys you an indirect protection for those who aren't directly protected. We use this strategy to think about vaccination policy all the time. It's what tells us how much of a population we need to vaccinate, for example, to be able to eliminate a disease, and it's been hugely important with vaccine preventable childhood diseases like measles and even with smallpox. This was a very, very important aspect to having smallpox eradication. The new suggestion that's being made by a small group of individuals, some of whom are scientists, but not most of them are not infectious disease researchers. And then there's also businesses that are involved in this strategy suggestion. It's called the Great Barrington Declaration, if some of you have heard of it. And it basically suggests implementing this, not with the vaccine, which gets you to immune protection without clinical disease, but with actual COVID infection. So their idea is to suggest that we just let COVID run rampant in the population, and that the disease will automatically stop at some point when it runs out of fuel, and then that will end up, being a good outcome. I'm here to tell you, unfortunately, this is a foolhardy idea. In the context of COVID, as we talked about earlier, there's a lot of severe clinical outcomes that we need to worry about. So if we're letting disease spread in a wide way across the population, we're talking about a lot more deaths and a lot more long-term disability, a lot of illness that we will be dealing with. Our public health systems aren't equipped to handle this. Our hospitals aren't equipped to handle this. And frankly, I just don't want to live in a society where the way we deal with an infection is just by letting people get infected. If we have tools at our disposal, and those tools, again, are still masks and social distancing and limiting gathering, right? Those tools are still the ones we should absolutely be using to deal with this disease.
It's amazing that over 100 years after the 1918 flu, we are still debating things like masks and social distancing, but we are. And before the session started, you said that you had been looking at some historical photos and that you had hoped that we could kind of end looking at this historical perspective. So I'd love to give you that opportunity right now.
Absolutely, absolutely. So I'll bring this slide up. So I'll say, folks, right, that nobody can argue that this year hasn't brought a lot of suffering. There's been devastation in our communities, and there's been a ton of personal challenges that everyone is dealing with. But we have to sort of come back stronger from this. So on that note, as Dr. Sanford mentioned, I'm just wanting to leave you all with this sort of historical perspective. This photo up here on the left is of my institution, Georgetown University. This is a photo of clerks at a university that are summarizing data. This one is of a class, a university course being taught outside, and then a university football team that's playing outside with masks, if you can't quite see it. So this photograph, all these images are from the 1918 influenza pandemic, just like Dr. Sanford just mentioned. At the time, most universities were home to student army training corps for World War I. And really, when cases started rising with influenza pandemic in the fall of 1918, universities stopped in-person classes, and the Army training corps on campuses went into lockdown. So despite sort of dealing with the World War, a devastating pandemic that killed millions of people, no vaccine on the horizon, and no Zoom, scientists and university science and university sports even survived after this period. They not only survived, but they thrived to become the powerhouses that they are today. And I really think we can too. So thank you so much for having me today.
Thank you so much. This has just been a informative and fascinating hour, and I think there are some more questions out there that may be coming to you on Twitter, looking at our question and answer session over here. But everyone, thank you so much for joining us today, and we will have another session in this distinguished speakers series on October 30th. That's next Friday, 2 o'clock p.m. Eastern Time, with Dr. Jesse Abate, who is an infectious disease epidemiology and data analysis consultant. Once again, thank you so much. This was wonderful. Thank you.
Thank you for having me.